Hello, my name is Jenny Pagel-Guile. I am the Executive Director, and on behalf of the National Pancreas Foundation, thank you for viewing this webinar. You are part of our mission, and as we focus on supporting the education of our care providers, patients, and our medical community. We also want to provide additional information, so you are able to follow us on Facebook. We have a new Facebook page. Make sure that you can follow us for all the up-to-date information and upcoming events that we have in your community. And we are also on a variety of other social media platforms for you to follow. In addition to your participation in this webinar, we are always looking for volunteers. So if you would like to be a presenter of a webinar and have a subject that you are interested in presenting on, or if there are events in your community such as Pancreas Bowl, we have galas, we have advocacy efforts, and a variety of opportunities to engage with the National Pancreas Foundation. And we look forward to seeing you soon. Today's topic, Improving Representation of Minorities in Pancreatic Disease Studies, is moderated by Dr. Cemal Yazici, and Dr. Yazici is a physician-scientist gastroenterologist with a focus in pancreatic diseases and health inequities. His research focuses on understanding contribution of diet, gut, microbiome, and microbiometabolics in acute pancreatitis in the context of healthcare inequities. He co-leads the Chicago Clinical Center for Multi-Institutional Type 1 Diabetes and Acute Pancreatitis Consortium. African Americans and Hispanics form the majority of his patient population at the University of Illinois, Chicago, and he takes care of patients living in the underserved neighborhoods of Chicago. These facts led him to further focus on health inequities and pancreatic diseases. He co-chairs the Recruitment and Retention Committee for T1DAPC, works closely with nonprofit organizations such as the National Pancreas Foundation, and serves as a co-chair for the NPF's AAI, along with Dr. Conwell. The multidisciplinary research team that Dr. Yazici leads at UIC contributed to development of the most diverse acute pancreatitis cohort in the U.S. More than 90% of patients he enrolls into pancreatic disease studies at UIC are minorities and exemplifies the service his team provides to underrepresented communities.
Thank you, Jenny, for that warm introduction and welcome. This webinar tonight is titled Improving Representation of Minorities in Pancreatic Disease Studies. There are noticeable health inequities in pancreatic diseases in minority communities. And health inequities in pancreatic diseases didn't receive much attention until recently. And if we really want to understand the root causes of these health inequities, we need to know the facts, the data, identify the challenges related to these inequities, and most importantly, engage and increase representation of minorities in pancreatic diseases. This is the main context of our webinar tonight, and we have great speakers to cover these topics. Our first speaker is Dr. Choate. Dr. Choate is an assistant professor of epidemiology at the University of Kentucky College of Public Health. Her research focuses on epidemiology of chronic diseases, including diseases of the pancreas, as well as health inequities, quality of life, and social determinants of health. She works closely with Dr. Darwin Conwell on several epidemiologic studies in acute and chronic pancreatitis. She will be discussing health inequities in pancreatic diseases, specifically in pancreatitis. With that, I give you Dr. Choate.
Thank you, Dr. Yazici. In my talk today, I will provide an overview of healthcare disparities in acute and chronic pancreatitis. My presentation aims to summarize existing data on healthcare disparities in pancreatic diseases and offer insights into current research in this area. The burden of pancreatitis, both in the United States and globally, is substantial. Although it is challenging to accurately estimate this burden due to methodological differences and diagnostic variability, especially in chronic pancreatitis. Research shows that pancreatitis disproportionately affects certain sociodemographic groups, particularly racial and ethnic underrepresented minorities, resulting in substantial disparities in health outcomes. Health disparities in pancreatic disease are multifaceted. They're influenced by a number of factors, including patient-level factors such as sociodemographic characteristics, disease-specific characteristics, healthcare system-level factors, including physician and hospital-related factors, and overarching factors related to social structures and economic systems. First, we'll delve into the patient-level factors that contribute to health disparities in pancreatitis. These patient-level factors include sociodemographic characteristics, such as racial and ethnic disparities, sex and age-related differences, and social vulnerability. Studies indicate significant racial and ethnic disparities in the epidemiology of pancreatitis. African Americans experience a 2 to 3 times higher incidence of acute pancreatitis compared to white individuals, and also have a high incidence of chronic pancreatitis. Similarly, high rates of acute pancreatitis are reported among Native Alaskans and Maori populations, which may be linked to high rates of tobacco smoking, alcohol consumption, and obesity within these groups. Hispanic populations have a higher incidence of biliary acute pancreatitis, primarily due to an increased prevalence of gallstone disease in this population, mainly attributed to dietary and lifestyle factors. Research demonstrates sex differences in the prevalence and etiology of pancreatitis. Men are more likely to present with alcohol-related pancreatitis and to develop adverse outcomes at high rates. Women more frequently present with gallstone-associated pancreatitis. Studies also show age-related differences in pancreatitis outcomes, with older patients often presenting with atypical symptoms, delayed diagnosis, and higher mortality rates. This highlights the importance of early diagnosis and treatment in this population. Social vulnerability refers to the susceptibility of certain social groups to adverse outcomes influenced by factors such as socioeconomic status, household characteristics, housing type, available transportation, and racial and ethnic minority status. Research on social vulnerability in acute pancreatitis, as well as chronic pancreatitis, is currently limited, mainly due to a lack of longitudinal studies and low minority enrollment. However, several recent studies indicate that minority patients with acute pancreatitis exhibit higher social vulnerability, which may impact the progression and recurrence of acute pancreatitis. This highlights the complex relationship between race, ethnicity, and socioeconomic factors. The second group of patient-level factors associated with health disparities in pancreatitis are disease-specific characteristics, including exocrine pancreatic insufficiency, diabetes, and other comorbidities, musculoskeletal health, disparities in pain management, and mortality. Research indicates that certain disease-specific characteristics can increase the risk for the development and severity of pancreatitis, leading to worse outcomes. These include an increase in local and systemic complications, resulting in, for example, higher medical costs, higher readmission rates, and mortality in certain populations. Studies show that osteopathy is common among patients with chronic pancreatitis. The odds for developing osteopathy is higher in older adults, women, white individuals, and those with a low BMI. racial minority groups with pancreatitis often experience more severe pain and face disparities in pain management and the quality of pain care they receive. Research has also highlighted disparities in mortality related to pancreatic disease. For instance, mortality from acute pancreatitis is higher among African Americans, men, individuals over 65 years old, those with low income, and those with additional health conditions. The next large category of factors contributing to healthcare disparities in pancreatic disease include healthcare system level factors. These include hospital factors such as rural versus urban hospitals, their location and access, insurance coverage, as well as financial burden. Studies show that rural hospitals often lack resources and expertise needed for complex pancreatitis care. Similarly, urban hospitals serving minority populations also struggle with resource constraints and limited funding. Additionally, geographic barriers and challenges with transportation further restrict access to care, exacerbating healthcare disparities in pancreatitis. Research shows that underserved populations are disproportionately affected by a lack of insurance or being underinsured, leading to significant financial strain, placing a heavy burden of financial costs not only on healthcare system at large, but also on individual patients, their caregivers, and families. Physician and provider-related factors contributing to the healthcare disparities include referral bias, language barriers, health literacy challenges, as well as physician burnout. Factors such as implicit biases related to race, ethnicity, socioeconomic status, or insurance can lead to inequities in accessing timely treatment. Studies show that challenges with health literacy and language barriers often result in suboptimal disease management and outcomes. In addition, a lack of physician resources and support services to meet the needs of socially vulnerable populations frequently contribute to physician burnout. And last but certainly not least, a major contributor to health disparities in pancreatitis is the complex interplay of social structures and economic systems. These multidimensional factors include structural and societal factors, social and physical environment, public policy, cultural factors, individual beliefs and values, social determinants of health, and social vulnerability of communities. Research indicates that healthcare disparities often stem from broader social and economic inequities. These systemic issues affect the daily lives and health of individuals, especially racial and ethnic minorities and underserved communities. By creating barriers to accessing resources and opportunities that support pancreatic care and overall health of communities. Factors such as lack of social networks, support systems, as well as unsafe and unstable housing, neighborhood conditions, contribute to disparities and adverse outcomes in pancreatic disease. To reduce these health disparities and promote health equity, it is crucial to emphasize cultural competence, respect diverse beliefs and practices, and address cultural trauma and systemic biases. These efforts can significantly improve health outcomes across diverse populations. In conclusion, understanding the complex underlying causes of healthcare disparities in pancreatitis is critical. in developing strategies to reduce the disproportional burden of pancreatitis on underserved minority populations. I appreciate the opportunity to speak with you today. Thank you for your time.
Thank you, Dr. Choate. Next, we will hear from Dr. Darwin Conwell. Dr. Darwin Conwell is a distinguished physician and academic leader who currently serves as the chair of the Department of Internal Medicine at the University of Kentucky College of Medicine. Dr. Conwell's journey in medicine has been deeply influenced by his upbringing in Appalachia, and he expressed a strong commitment to improving healthcare access and outcomes for underserved populations, particularly in rural areas. His research and clinical work have focused on chronic pancreatitis, diabetes, pancreatic cancer, with a special interest in the interrelationship between these diseases. Dr. Conwell is also known for his dedication to mentoring the next generation of physicians and researchers, emphasizing the importance of inclusivity and addressing health inequities in the medical field.
All right, thank you, Jamal. I really appreciate the opportunity to speak at this webinar. I'm going to be discussing the role of social determinants of health in the pancreatic disease care continuum. So we'll be talking about social determinants of health and actually discussing closing the disparity in pancreatic diseases in the Black and African American community and discuss some strategies for doing that. So what are social determinants of health? Social determinants of health are the non-medical factors that influence health outcomes. They are conditions in which people born, grow, work, live, and age in. They actually impact up to 80% of our medical outcomes. And it's really the wider set of forces and systems that shape the conditions of our daily lives. Things that we have to confront are these forces and systems include economic policies, development agendas, social norms, social policies, racism, climate change, and political systems. Factors contributing to disparities such as social determinants of health impact the entire pancreatitis care continuum, including the etiology, which is the cause of pancreatitis, whether it's alcohol abuse or smoking, the diagnosis, do you have access to the care to make the appropriate diagnosis, recovery, do you have access to come back to your physician or healthcare provider, do you have transportation, prevention strategies, smoking cessation, alcohol cessation, dietary and nutrition access, food swamps, food deserts. These are all things that impact the pancreatitis disease continuum and are wrapped in our social determinants of health. Very proud to say that the National Pancreas Foundation has launched a Black African American initiative. And you may ask, well, why is that? It's because African Americans have the highest incidence rate of pancreatic cancer in the United States. Well, how do we close the disparities gaps in the Black community? There are multiple things that can be done. If you look over to the left, we can modify high-risk behaviors such as tobacco and alcohol use that we know contribute to the development of acute pancreatitis, chronic pancreatitis, and pancreas cancer, and also their severities. We also can modify our weight, our blood sugar in terms of, are you obese? What about exercise? What about nutrition, healthy lifestyle, diabetes, lowering our blood sugar, controlling our diabetes? Do we have access to the appropriate medication? Does that impact our care? And it definitely does. Access to healthcare, transportation, conditions known as financial toxicity, actually having the availability of the healthcare in your system, but you may not be able to take advantage of that due to transportation issues or economic issues. So access to healthcare, that is a major barrier that's enveloped in our social determinants of health that does impact our outcomes. Access to health education. Are we being explained and taught how to eat, how to cook, how to exercise to improve our overall health? When we're talking about closing the gaps and disparities, we all have to be part of the solution. So I'm going to challenge us all to be the change that we wish to seek in our world. It is well known that several famous African Americans have passed away from pancreas cancer. And so this is a known factor in the Black community and African American community. But we must develop community partnerships. We must get into the community to take the message to them, to enhance health education, and also break down some of the barriers that exist. This is just one example. In Lexington, Kentucky, my wife and I are at a Barnstable Brown Diabetes Center, has a community health and wellness event every year. This has grown exponentially in the 3 years that we have been here. But we are there passing out materials from the National Pancreas Foundation, cookbooks, literature on pancreatitis, smoking cessation, alcohol cessation, and educating the community in pancreatitis and pancreas cancer. Other advocacy groups are throughout the country, throughout the world. They include the Pancreatic Cancer Action Network, Hirschberg Foundation, and other foundations that are working together to eliminate disparities, working together to decrease the incidence and development of pancreas cancer, and also to improve the treatment and management of these disorders. We need academic partnerships. We need academic partnerships for our research to do better studies that will be more applicable to underrepresented populations. This is our Marquis Cancer Center at the University of Kentucky, led by Dr. Mark Evers. We have a lot of clinical trials. This is an NCI-designated comprehensive cancer center. We're very proud to have that recognition. But one thing for sure, we need to get underrepresented populations such as African Americans in clinical trials. Unfortunately, there is a dark past that we have to deal with, but I say we deal with it and embrace a brighter future. But access to care, actually having the availability and the awareness and education of the clinical trials, and being able to trust the providers and the researchers enrolling subjects in the clinical trials is very important. So we must face this dark history, but also, but I would say, embrace a brighter future. We need health education and health equity. As I've mentioned previously, the National Pancreas Foundation has really launched a comprehensive strategy. I refer all of my patients to the NPF because they have this DigiReach download. There are multiple webinars, animated patients. There's actually camps for children with pancreatitis that are free. There's a lot of information on where we're having webinars, health fairs, festivals, clinical trials that are being launched, but you got to get into the community. You got to get into the churches. You got to get into the faith-based organizations, get to health fairs and touch the people, get them the information to actually change their habits and behaviors and educate them on a better lifestyle. This is the NPF pancreas cookbook that gets thousands of downloads. It's a very popular cookbook, has great recipes, and I would encourage you to download this for free. Another example of the Barnstable Brown Diabetes Health Fair that we went to, and we have even the Food Connection, which is a group that actually teaches you how to cook, what to cook, how to cook it, how to prepare it, so it's a healthier lifestyle, low fat, low cholesterol meals. The NPF has sponsored multiple webinars to engage our providers, to engage our researchers around a dialogue and conversation to educate our communities. We're very proud to be a part of those, and this is just one of the webinars that was sponsored, and some photos from other events in Lexington, Kentucky. I really like talking about life's essential aids. The American Heart Association has put together 8 key essential things that we must do to maintain our health. This impacts cancer, it impacts heart disease, it impacts diabetes. Here's what we need to do. Eat healthy, stay active, get enough sleep, don't smoke, maintain a healthy weight, control our cholesterols, manage our blood sugar, keep blood pressure in a healthy range. If we do these essential 8 things, we will be happier, healthier, live longer, have less cancer, and less poor outcomes if we do get sick. The other thing I'll tell you, in addition to life's essential 8s and social determinants of health, is we just received a grant at the University of Kentucky from the National Institute of Minority Health Disparities, and it's called UK Ascend. We need to change our workforce. We need to provide workers in these spaces that look like the people that they are serving. So this is called Achieving Success in Community Engaged Research to Eliminate Disparities, UK Ascend. We're very excited to just receive this grant, and we're going to be educating and training community engaged workers to go into the community to educate them and do research that touches them and impacts change. I'm going to give you one example of a published community engaged research project that was done at The Ohio State University when I was there, called the Black Impact 100. This is the African-American male wellness walk that goes on throughout the nation every year in large cities throughout the country. And they decided to take 100 Black men, give them health coaches, give them exercise and health education, mental health education, and see if they could impact their lifestyle, can impact what we called at the time Life Simple 7. We've added, it's now called Life Essential 8, but at the time it was Life Simple 7. We've added sleep to the American Heart Association guidelines. The goal was to lose 7% of their body weight and achieve 150 minutes of physical activity a week. So this is community engaged research, actually going to the community and exercising them at the parks, exercising them in parking lots. This actually happened during COVID. They were actually exercising people and giving them lifestyle changes, wearing masks in the park systems of Columbus, Ohio. So we wanted to evaluate, they wanted to evaluate, could they impact the Life Simple 7 score? Could they improve that score? And why is that important? Because Black men have the worst scores. And so the mean age of the patients was around 52 years of age. It was a socio-demographically diverse population. You can see the percentage of people who were college graduates and had private insurance. 84% were employed. On average, they lowered the Life Simple 7 score by 1 point, just 1 point. And what does that mean? A 1 point lower in the score decreases your cardiovascular risk, your stroke risk, your myocardial infarction risk, your cancer risk. So this is really a big deal. So community engaged research really can impact change. And this is just one example. It's been published. That's the article. And they are doing more research like this. Others are doing the same thing. At the University of Kentucky, Laura Williams has led a diabetes intervention across the United States. That's the largest intervention in the NIDDK, looking at diabetes management in Black churches and really attacking those disparities. So to wrap up, social determinants of health definitely can impact our pancreas disease care continuum, from diagnosis to treatment to follow-up and long-term management. We definitely need to close the disparities gap in pancreatic disease. The NPF has launched this African-American initiative that's making a major impact across the country in cities such as Atlanta and Chicago, Lexington, and others. We need to reestablish trust and deal with the past, but get on with it, embrace a very bright future. We have partnerships that we need to continue to foster throughout the nation, including our community partners, nonprofits, academics, and industry and advocacy groups. We need to modify our risk. We as a nation need to lose weight. We need to control our glucose levels. We need to embrace Life Essential 8 from the American Heart Association and live a healthier, happier life. We need to advance health equity, educate people, tell them about what they need to do, and we need to expand our provider workforce. And that's what we're going to be doing with UK Ascend. So be the change that you wish to seek in the world. I'll end with this. If not us, then who? If not now, then when? Thank you very much, and I appreciate the opportunity to spend this time with you.
Thank you, Dr. Conwell. Our next speaker is Dr. Fiyinfolu Balogun. Dr. Balogun is a medical oncologist specializing in gastrointestinal tumors, including pancreatic and colorectal cancers. He completed his undergraduate degree at the University of Maryland, Baltimore County, then completed his MD PhD at the University of Chicago with a dissertation on DNA repair. At New York University, he trained in internal medicine, then completed his hematology oncology fellowship. He subsequently joined Memorial Sloan Kettering Cancer Center in New York City. His research involves better understanding the molecular basis of these pancreatic and colorectal cancers, with an emphasis on underrepresented populations.
My name is Fiyinfolu Balogun. I'm a GI medical oncologist at Memorial Sloan Kettering Cancer Center with a focus on pancreatic and colorectal cancers. And today I will be talking about improving minority representation in pancreatic cancer studies. While this talk is mostly focused on Black and African American individuals and pancreatic cancer, as we've been seeing, this is the points here are applicable to other minoritized groups and several other cancer types too. In the US, Black individuals make up 14% of the population as of 2020, thus comprising the third largest racial ethnic group. I like to start with stating that race is a social construct and not biologically inherent. And a lot of the inequities in health that we see are primarily driven by structural racism. When you look at pancreatic cancer in the Black and African American community, we see that it is the fifth most commonly diagnosed cancer, but it is the third most common cause of cancer death. This mirrors what we see in the general population in terms of being potentially as low as the eighth most diagnosed cancer, but still the third highest cause of cancer deaths. That difference, that increase, when you look at the percentage it comprises of 4% of diagnosed cancers to 8 or 9% of cancer mortality, cancer deaths, that jump is the highest amongst all cancers, and understandably is a reflection of why pancreatic cancer is one of the most fatal or one of the cancers with the highest mortality rates. When you look at the Black African American individuals, they have a higher incidence, a higher chance of being diagnosed with pancreatic cancer. And this is compared to non-Hispanic white, non-Hispanic Asian, Pacific Islander, non-Hispanic American Indian, Alaska Native, and Hispanic individuals. Within those patients who are diagnosed with pancreatic cancer, Black individuals also have the highest mortality rates of pancreatic cancer from pancreatic cancer. Black patients that have been diagnosed with pancreatic cancer, has been noted that they tend to present with the more advanced stages of the disease. So at the time of presentation, when they're being diagnosed, they're more likely, as we see, to be compared to non-Hispanic white patients, they're more likely to have distant metastatic disease, and less so for the localized or the regional ones that have not spread too far away. When you look within each stage, Black individuals, Black patients with pancreatic cancer are less likely to receive systemic therapy, surgery, or radiotherapy, and they're more likely to refuse treatment. All these things and more contribute to the disparities we see in pancreatic cancer outcomes. When we classify these factors that are associated with the incidence and mortality, the outcomes we see for pancreatic cancer, we can view them as modifiable and non-modifiable. Some of what I'll be discussing today will touch on a couple of those points. Under the modifiable bucket, we'll touch on access to healthcare, and the non-modifiable ones, we'll talk on genetics, potential differences in biology. The question mark there indicates or suggests that this is not a very clear point yet. And more specifically, when we're thinking of the differences in biology, while there are several indications or suggestions, I will be talking more about KRAS mutation profile. Now, KRAS is the most commonly altered oncogenic driver of all cancers. When you look across all cancers, that's the #1 mutated gene, and it drives a lot of the cancers. This is particularly evident or the case in pancreatic cancer, more so than any other cancers. In pancreatic cancer, you look across everyone, it's about 90%, 85 to 90% of pancreatic cancer tumors have a KRAS mutation that's driving the cancer. KRAS has been very hard to drug. For decades, the goal has been to try to target it, but we have not been able to do it successfully until recent breakthrough, whereby more specifically in lung cancer, an inhibitor drugs that could target the G12C mutation in KRAS were identified and have since been approved, so they're available for regular treatment now. As you would imagine, this was also looked at in several other cancers, with such success being in lung cancer. And here what we see is the studies looking at one of the studies that looked at KRAS, the sotorasib, which is an inhibitor for KRAS G12C mutation in pancreatic cancer, in patients that had already gone through available chemotherapy options. We see in the top right corner here, the graph does show us the tumor size, the tumor response. Bars that go down suggest that the tumor is shrinking, and bars that go up so that it's growing, and each individual bar represents a patient. And we see that in most of the patients, there is a response. When it goes beyond the dashed line, that's considered a response, but anywhere between the hard line and the dashed line is stability in the disease. There was also 4-month progression-free survival and a 7-month overall survival median from the time when they were started on this treatment. While those numbers are not particularly mind-blowing, for disease like pancreatic cancer, metastatic pancreatic cancer, where the median overall survival is under a year, for patients who have already exhausted their treatment options, this was a pretty significant shift. However, when you look at the KRAS type of mutations that are present in pancreatic cancer, G12C makes up just 1 to 2%. So most of them, it does not affect or does not help most of our patients that have KRAS mutation. Speaking a little bit more about what these KRAS mutant variants, why they're of importance in pancreatic cancer. The mutations, the specific variants for KRAS, for KRAS that we see, they're quite unique. So a drug that can effectively treat KRAS G12C would not work, in this case, would not work for the others. So you have to target specific variants to design drugs that would actually treat them. When we look at the variants in pancreatic cancer overall, the most common variant is the G12D, then the V and the R. Now, interestingly, as we start to look at, albeit in smaller numbers, of Black and African individuals with pancreatic cancer, the G12D is not the most common mutant variant. It's actually the G12V. The way the cancer behaves when it's led by a G12D or a G12V appears to be different. And obviously, the drugs that they respond to are different when you're using KRAS-targeted drugs. So we're seeing now that the most common mutants in all groups is not necessarily the most commonly seen variants in Black and African-American patients who have higher incidence and higher mortality from pancreatic cancer. But the design of drugs is influenced more heavily by the frequency of what mutants we're seeing. So lots of new KRAS drugs, it's a very, very, very hot topic. Lots of new KRAS-directed drugs are on the market now, are in clinical trials. And when you look at the mutant-specific ones, they're mostly or predominantly G12D. That's the most common one that's seen. You have others that are targeting multiple cancers, but the G12D tends to have the higher level of focus. Now, this tells us that the more the frequency of a mutation, understandably and reasonably so, the more interest it garners in terms of drug design. Where does all this information come from about the frequency of the mutation? So still staying with our KRAS as our example here, when you look at the genomic databases, which is the database from which drug designs, tool designs for diagnosing diseases and cancers, the database is where you get that information upon which they're built and designed. We see that minority patients, minoritized patients, Black and African Americans in this patients in this particular example, are significantly underrepresented in these databases. Here we see the cancer incidence of the US population demographics, and we see that about 60% are identified as white, 14% Black, 6% Asian, and 20% Hispanic. But when we look at some of the larger databases, the genomic databases, we see that 80+% are white, and that goes up from the 60% we see in the US demographics. But when we look at Black or African American individuals, you see this is 7%, maybe as high as 10%, but easily half of the US population demographics. And we know that the incidence, the probability of developing cancer is pretty close when you look at Black and non-Hispanic white individuals in the US. So this is clearly showing us that when these genomic databases does not represent or does not capture enough of what we see, the diversity that we see in our cancer, in our population and people who are being diagnosed with cancer. And this is a big part of what leads to drugs being designed that may not necessarily account for everybody, appropriately so. And this refers to the high focus on the KRAS G12D mutant variant and less so on the G12V. But if we had more information in the databases that showed or reflected how significant KRAS G12V is, that could affect the choice or could increase the frequency of G12V design drugs. Moving on to clinical trials, looking across the board across different racial and ethnic minority groups, we see that similarly, the minority groups are significantly underrepresented in clinical trials. Now, this is the figure from before of the US population demographics, and we see here for race and ethnicity, clinical trial representation. Over time, we see that it's about 85% that we're looking at over the course of 15 years through 2020 in the white patients, the non-Hispanic white patients, compared to 8.2 for Black, 2.4 for Asian Pacific Islander, 0.3% for American Indian, and 8.5 for Hispanic. But 20% of the population is Hispanic, 14% is non-Hispanic Black. And we see the difference here with the ethnicity, where it's about 10%, less than 10%. So not only are the minoritized groups underrepresented in the genomic databases, which lead to the design of the drugs, but in the clinical trials, where a better understanding of the drugs and the access to these novel agents are taking place, they're also significantly underrepresented. So this does show us or paint a picture for us that there is a problem. Understandably, there are barriers to patient participation in clinical trials. And several of these are historical, which we're very well familiar with, thinking more specifically of the Black and African American community. There is the mistrust of the health system from the history of exploitation and deceit. Several of these barriers continue to exist, and several of these treatments where people feel not as welcome or supported still exist. So this is not stuff that's historical, but these are for the historical context. So the HeLa cells, sulfonamide, for southward in children, several in the Tuskegee trial, which is very well known. It wasn't until the 19th century that informed consent, where you actually would get the permission of patients to be participants in clinical trials, became established and standardized. Looking into specifically clinical trials and how they're actually going on today, how they've been executed today, some of the barriers that we face currently include strict eligibility criteria, and I'll touch on that shortly. Inaccessibility of the trials. A lot of trials tend to be in institutions or large institutions, academic institutions that may not be easily accessible to everyone based on geography and resources. Poor community engagement. We've heard multiple times about the importance and value of community engagement. And these barriers exist at every level, from the scientist to the participant to the study. One of the key ways of actually addressing these barriers to clinical trial participation is to be aware and to think of these barriers at the very beginning when the clinical trials are being designed. Engage the community early. That would help give information or education about the barriers and also build trust. It's always important to remember that engagement is not the same thing as recruitment. Engagement does lead to recruitment, but they're not the same. So a couple of steps I'll mention to improve clinical trial recruitment. The first is to design inclusive clinical trials. There was a study that was published recently, just a couple of years ago, looking at pancreatic cancer patients and the traditional criteria for clinical trial inclusion and exclusion. There were significant differences in some of the lab tests that were performed when you look at the baseline lab tests between Black and white individuals. And it was noted that some of these differences actually did lead to a higher number of Black patients being excluded from the clinical trial compared to white patients. And we see those with the asterisks here that do show us that they were clinically statistically significant and did lead to a difference, more significantly so. The albumin lab, HIV, hepatitis B and C status being some of the examples. Now, they looked further, and with some of these criteria that led to increased or disproportionate exclusion of Black patients from the trial eligibility, they looked and said, can we revise the criteria, still maintaining safe, still making sure that we're staying within the safety, within the range of safety. For example, with renal function, a creatinine clearance of greater than 30, which is also being recommended by the NIH as safe for these interventional clinical trials. Some other examples include for those who have been diagnosed with HIV or hepatitis B, if they're being managed on medications, there should be consideration that they're safe to participate in the clinical trials. Those who had prior cancers, as long as they're not on any active treatment or remission, and also those with diabetes, they can be started on treatments to allow them to participate in the trial. They saw that with this revised criteria, a lot of that difference in terms of ineligibility that you see disproportionately affecting the Black patients, a lot of it was wiped out. And everyone across the board benefited, both white and Black patients. Were less ineligible for the trials, but that disparity importantly was eliminated just by making changes to a few eligibility criteria without sacrificing safety. Now, what that tells us is that some of these, there could be simple steps where we're just more thoughtful about our criteria for eligibility of clinical trials, and that will contribute to improving our recruitment and enrollment in clinical trials for racial and ethnic minority patients. Number two is to engage the community and to truly engage the community. Define a community. Could be geography, could be identity, could be experience or social interactions. Should note the difference between collaboration and participation. when a PI, a principal investigator, or scientist conceives an idea and invites the community, they're inviting them to participate in their idea and their study. However, when the PI and the community come and sit together and make sure that they're engaged and involved in all aspects of the trial, really from the idea, from the conception of the idea through the execution of the trial, that's collaboration. And several ways to engage the community and utilize community advisory boards, community workers, patient advocates as part of the research team. And it's also important, less spoken about, is the dissemination. Typically, when clinical trials are completed, the results are published in scientific journals and disseminated to the scientific community, the medical community. However, making sure that the results, the findings, the implications are communicated back to the community will serve to build more trust and promote continued partnership. And a lot of participants in clinical trials do express a desire to know what the findings were from the studies or trials in which they were a part of, even if it didn't serve to help them. There was a study from a while ago, really, but still very pertinent, where that emphasized community relationship building. The goal was to recruit Black patients with breast cancer into a clinical trial. There was a lot of emphasis on relationship with the community and engagement of the community to do that, both from the marketing, making sure that the social marketing was targeted to the specific population, in this case, Black African-American patients, Black and African-American patients, for products, for medias and activities that were more targeted towards them. This was contributed to by past research participants, patient advocacy groups, and there was also the consistent interaction between the scientific team, the principal investigator, and the participants along with the recruiters. The PI and the trial team sent letters to the community frequently and actually made visits there too. They noticed that these measures actually led to a 2/3 increase in the eligibility in eligible patients being recruited successfully into the trial. So it was a reflection or was showing that community engagement does translate into increased patient recruitment into clinical trials. It's important to know that community engagement is not something that is innate, not something that we just know and are naturally born with. Similar to how we need to learn to participate in clinical trials, it has to be taught it has to be in a structured manner, it has to be learned. And beyond just learning it, it has to be cultivated, nurtured, and it has to be updated. And for each specific environment, it has to be personalized and not just a method of community engagement that was designed to work in designed within a Black and African American community to be just cut and applied to an East Asian community, a South Asian community. So for each group, it has to be personalized. Nowadays, we see more, with the reflection of better appreciating this, we're seeing more programs that are focused with and integrated as a part of their award. We need to teach the ability to engage with the community. Third and final point that I'll make, and not the end of all the points, but just 3 points I wanted to highlight, is to improve access to clinical trials. Now, within an institution, there was actually a study where just about 10 years ago, that was published about 10, 11 years ago, where in one NCI designated cancer center, we decided to look at how to successfully improve access for patients in the community to the clinical trials. And several things came out of it. Leadership support was important. An infrastructural process which follows leadership support, the leadership buy-in is key. And they made it a center-wide requirement for every study to prioritize clinical trial diversification. And not only was that mandate there, but there was a reporting mechanism where they were actually able to monitor and see what the studies were doing. And that would allow for analysis of the data to determine whether this was effective, this was helping, and how to better improve it. There was a real risk of closure for the studies within that institution if they were not meeting these goals. So this goes back to the leadership support and buy-in, make sure that this is something that actually has a lot of support, a lot of weight behind it. And they saw that there was a 60% increase in minority patient clinical trial enrollment. Overall, there was an increase in minority patient visits to the institution, but just focus on the clinical trials was 60%. So not only does it help with the clinical trial enrollment, but it also helps with overall care or access of care for the minority patients in that community. There were also some other points that came out of this was the need to take as much as possible the trials to the community. And this comes back to one of the things I mentioned in terms of access, where the large academic centers, and they may not be in the minoritized communities, so it limits the access to them. They're establishing a presence, whether by collaboration with community health centers or by building sites in those minority predominant communities, is one of the ways to improve access. Several studies have also shown that patient navigation and coaching is important for increasing clinical trial recruitment and enrollment. And just to mention a couple of examples here, looking at American Indian patients, historically less than 1% participate in clinical trials, a very dismal number. Using culturally competent navigators, they were able to actually increase that number in this study to 22%, from less than 1% to 22%, just by using navigators that were competent of what mattered culturally to the American Indian community population there. There had been instances prior to that where the navigators were used, but not anywhere near this successful. Another study trying to screen, with a goal to screen Black women for potential clinical trials, used an oncology nurse navigator, and just the use of that nurse navigator who would serve as both as a conduit between the academic institution and the community, increased, more than doubled the Black patient participation over the course of 2 years. And also racial concordant patient navigators, where people in the community were trained as patient navigators for clinical trials, were seen in another study to increase Black patient population 16%, up from 9% over the course of 7 years. 80% of patients that were eligible enrolled, so a significant proportion were enrolled. And these, as we know, that patient navigation is very helpful, very vital for care access, but even more so for clinical trial enrollment and engagement. In summary, racial and ethnic minority populations significantly across all cancers, but particularly within pancreatic cancer trials, are underrepresented, both in the trials, which are the therapeutic trials with the novel agents and drugs, but also in the database, the genomic databases upon which the newer drugs are being designed. We need to educate, encourage, and support patients in order to increase their ability to enroll in clinical trials. Many patients have expressed that, and has been published, has been shown that patients express the desire to participate in clinical trials as long as they understand what it's about, and also have some improvements in the access to it. Eligibility criteria should be more inclusive, and this can be done without necessarily sacrificing safety of the drugs or the integrity of the findings of the clinical trial. Partnering within the community cannot be understated, cannot be overstated. Engagement is something that is very vital to increasing clinical trial support or clinical trial enrollment, but it also needs to be taught. It's not something that we're born with. It has to be, we have to learn it and we have to cultivate it. Improving access to clinical trials, and something that ties into all of these is to budget appropriately for clinical trials. When clinical trial grants and budgets are being designed or are being submitted, very often they don't include the allowance for what it'll take to engage with the community, whether it's the community board, whether it's a community advisory board, or efforts and the work that will take to engage with the community. If this is not included in the budget, then it's not going to happen to the extent, to the robust extent in which it should happen. Thank you very much, and special acknowledgement to my co-PI, my co-investigator, Devyani Chakravarti. Hopefully with this discussion or from this presentation, been able to give a sense about the importance and some of the steps in which we can take to increase clinical trial enrollment for pancreatic cancer patients from racial and ethnic minority communities, especially the Black and African American patients.
Thank you, Dr. Balogun. I hope you have enjoyed our webinar thus far. For our last talk, I will be speaking on solutions for closing the gap in minority representation in pancreatic diseases. I have no disclosures. First, we will discuss the importance of increasing minority representation, and we will review the data regarding minority representation in pancreatitis studies. We will go over strategies to increase recruitment of minorities, and we will review some of the success in regards to improving minority representation in recent pancreatitis studies. Pancreatic diseases disproportionately affects minorities, as we covered, and we need to represent the entire population in our studies to be inclusive. Biomarkers and tools that are being developed should have large-scale applicability, and interventions and drugs that we develop need to be accessible and feasible to use by the entire population. That's why it's really important to increase the representation of minorities in pancreatitis studies. However, when we look at the data and review the studies that are published during the past decade in acute pancreatitis, recurrent acute pancreatitis, and chronic pancreatitis, although they address really important topics and really detailed that are published by our colleagues, you can see that on the right side, the representation of minorities is minimal. There is only one small study from California that has good representation of Hispanics. But if you look into entire study cohorts, you will see that minority representation in average is approximately 10 to 15%. So what are potential solutions that we can implement to close this existing gap in minority representation? We have four main topics, and they have some overlaps in between them. We will start with policy and review the community engagement, go over the interdisciplinary collaborative approach, and subsequently cover research. So implementation of policies to expand healthcare access for people from racial and ethnic minority groups have been successful, and they have been shown to improve health outcomes. Reporting race and ethnicity accompanied by other key social determinants of health variables is critically important. And this accurate and transparent reporting really reflects equity if we can achieve that. This approach has been well adapted in NIH-sponsored type 1 acute pancreatitis study named type 1D APC. It's implemented in its longitudinal diabetes related to acute pancreatitis and its mechanism study, as well as ancillary studies that were supported by the type 1D APC. The intersection of policy implementation and community-based participatory research also provides unique opportunities. It can involve and target important lifestyle factors such as diet, exercise, access to fresh produce, etc. However, it requires broader, long-term, and sustainable commitment, especially from policymakers. Community engagement is another area that we can improve. Engagement of minority communities is crucial for addressing health inequities. And community engagement advisory boards can play a key role here. Many large institutions have community engagement and advisory boards. They raise awareness and engage underrepresented minorities. It includes not only members of the research team, but also patients, caregivers, and community members. If they are engaged early on, they can help us to tailor the study protocol at the development stage for optimal engagement of minorities. Recruitment and innovation centers can also help in increasing minority representation. Also, another key ally in this area are non-for-profit organizations. They can help to raise awareness in minority communities and increase their participation through community outreach programs. In fact, the Black African American Initiative of the NPF has been playing a key role in that regard. It has already provided opportunities for active engagement and empowerment of African American communities. Interdisciplinary and collaborative research is another area that we can improve. The formation of these interdisciplinary teams is critical for increasing minority representation to reveal the underlying reason for health inequities. Investigators with expertise in health inequities can help with the development and adaptation of case report forms to collect key clinical data to study health inequities. Also, inclusion of experts who work with patients with pancreas disease within minority communities can contribute to development of tailored recruitment and retention plans, which can improve minority representation. Such multi-center studies also benefit from data coordinator centers, as they can improve scientific coordination, research computing, and biostatistics to facilitate inclusion and analysis of data related to health inequities. Adaptation and development of novel conceptual frameworks can also help examine the underlying structural factors for health inequities. Lastly, we need to improve minority representation to study underlying reasons for health inequities in our research studies. And for that reason, incorporation of geographical regions with really high density minority communities and participation of centers that serve minority populations within these regions in pancreas studies is crucial. Integration of key data points such as race, ethnicity, health literacy, housing, transportation, food insecurity, education, etc. in study protocols can help. Also, formation of a recruitment and retention committee before study activation to identify and address challenges related to minority participation is very important. Another key component of research is the presence of a diverse research team whose members have the required skills and cultural competencies. In the next few slides, I will provide some examples from recent pancreatitis studies. But first, we will review some of the key components for success in recruitment of underrepresented minorities. And these are pretty much based on our experience at our institutions. So a diversity and cultural component study team is very important. It really helps the study team to connect with the patient at personal level. Also, engagement of patients early during their disease process is very important. So time is very critical. The investigator also plays a key role in this recruitment process, and active participation of investigators with the patients helps to establish the trust, which is key in maintaining a really good retention. And also, detailed discussion is very important. These discussions with patients provide opportunities for education as well as empowers the patients. In regards to follow-up, if research teams can implement flexibility in their structure and also in their follow-up team, that will also significantly help in recruitment and retention of study participants. And also, at our side, we have been using local resources very often, and they significantly improve engagement of minority communities. And obviously the support, as we discussed earlier, most of our patients from minority communities, they may have significant lack of resources. So really being cognizant about the social determinants of health variables and providing the support to patient for their participation is very important. So using these strategies, we have completed a case control study in 2021 and successfully established an acute pancreatitis cohort that is enriching underrepresented minorities. Our institution is a research-found minority serving institution, and communities we serve identify themselves 48% as African American, 24% as Hispanic or Latino, 20% Caucasian, and 8% as Asian or other racial groups. And if you look into our enrollment numbers and percentage of minorities at the bottom, you can see that 80% of patients that we enroll into our acute pancreatitis group were African Americans or Hispanics. Although that was a small single-site study, we were able to successfully implement some of the strategies that we developed at our center in a subsequent multi-center and age-supported multi-institutional and age-supported study that looks into development of diabetes from acute pancreatitis. It's called Type 1D APC Consortium, and its longitudinal study is called the DREAM study. One thing you can notice right away from this map is the geographical diversity of these academic centers that participate in this prospective human subject study. So one of the first things the consortium addressed was a formation of a recruitment and retention committee. These clinical sites for the Type 1D APC consortium were selected carefully by NIH during the review process, included large academic centers and urban areas that serve underrepresented minorities. And some of our clinical centers predominantly serve African American and Hispanic communities. The goal here was to enrich the racial and ethnic diversity of the study cohort. And Type 1D APC formed the recruitment retention committee early on, way before its activation of the study protocol. And the main goal of the RRC was to enhance participant recruitment and maximize retention for this study. And RRC was also tasked to ensure minorities are being included in the study in an equitable way. So we review the screening logs regularly to evaluate inclusion of minorities. If their inclusion was limited, we identify the barriers for this limitation. We developed alternative strategies for improving their enrollment, and we informed the Type 1D APC steering committee about these findings, and if needed, implemented new strategies across clinical sites. And here you can see some of the components of the recruitment and retention plan that we developed as a recruitment and retention committee for the DREAM study. It had several components. We just summarized a few of them here. Raising study awareness, engaging the sites, developing strategies to engage participants, and also addressing potential barriers. And the Data Coordinator Center developed a website, and we also developed a main flyer and also site-specific flyer to engage potential study participants. And if you look into the representation of minorities in the DREAM study, at the top, you will see the data from our center. We are a minority serving institution, and you can see that more than 90% of patients we enroll at UIC are actually minorities. And if you look into overall representation of minorities in this multi-institutional study, you can see that it mimics US Census very closely. Racial minorities in the US Census is 24%. And as of last month in the DREAM study, we have 22.3% representation of racial minorities. And again, ethnic minorities in US Census is approximately 18%. And in the DREAM study, it's 18.9%. So this is the largest prospective acute pancreatitis study that is being developed in the United States. And we are actually forming a very inclusive study cohort that really represents racial and ethnic diversity of the United States. So in summary, we need policies and priorities to really engage and increase the enrollment of minorities. And local resources is quite important. So whether it's a community engagement board, CCTS, or a minority health research center, we really need to engage our institutional support centers in this process. And forming a diverse research team is very important for establishing the trust and engaging patients early on. And also, this early engagement is really important for long-term retention, because then you will have more time to develop the relationships and you will have more continuity with the patients. And we need to recognize and address structural barriers, as it was covered earlier. Especially patients from minority communities can have significant structural barriers, and we need to include potential solutions for this in our recruitment and retention plans. And finally, establishing a record is very important. It increases the trust and the retention rate in long term. And this can result in increased recruitment and retention of minorities, even in multi-institutional studies, as we can see in the DREAM study. So with that, I would like to acknowledge my colleagues whom I work very closely in regards to health inequities in pancreatitis, as well as the members of our lab.